This time the chair lays out HB10 and HJR5 and recognizes its author, Chairwoman Thompson, to explain the bill and the joint resolution.
Mr. Chairman, members, the substitute is merely adding some additional medical entities and personnel to this particular bill because it's going to be a bill that's going to be driven by research. This bill is to establish somewhat board similar to the secret that we did back when we did the cancer secret bill many years ago. I have been working closely with the UT Health Science Center in Houston and the Texas Legislative Council in drafting the bill and the substitute and the HJR5. And as you have watched the news all over the state of Texas, we have been looking at problems, and we've been inundated with shootings and fights and schools asking for more money and needing more money to put up security mechanism in the school to keep the kids safe. And in spite of all those particular things, nothing had really worked. So in an effort to try to find out why our kids are so violent, why is there such an escalation in the mental conditions of children, and then what are some of the unknown factors that we have not even discovered that may be happening and may be targeted in the brain of children that we need to investigate. This bill is an attempt to find out what are some of those unknown targets in the brain that's causing kids to be more suicidal, more violent. They say it's not the guns, so it has to be something else. And what I'm attempting to do is form an institute that's going to do research into these problems and see what we can come up with and whether or not we can find what some of these targets are, how do we treat them, and how do we develop protocol. The HJR5 is an attempt to fund it by a secret-like method to do this research. We're not building infrastructures because we have all the medical schools we want within our state, but we are bringing in together those medical schools, and we're asking for researchers, scientists to be a part of this research to give us some answers.
The chair calls up Dr. Elizabeth Newland and Consuelo Walsh-Bass.
How consistent is the advice that a child is likely to get through a network between the different professions? I mean, it seems like there's just a tremendous variety of thought in what that advice may be in terms of, the underlying reasons, as you mentioned. It's hard to imagine much consistency across the spectrum.
And I think probably what you're speaking to is how there are so many unanswered questions within psychiatry. We often talk about it being somewhat of an art instead of pure science, right?
And there's some that have been answered a long time and we ignore.
And that's absolutely true. The best practices are not well disseminated, and that's part of the challenge. I think that House Bill 10 will help with that. But when there are, when things are left to clinical acumen and the diagnostician to answer, rather than there being an available brain scan or blood test or diagnostic test that we can do to give you a solid, concrete answer, there's more variability in the answer that you're going to get, right? So if you go to your doctor and you get a tumor biopsy and they do, genotyping on that tumor, it's a very concrete answer. But when you're doing an interview with a patient and you don't have a blood test or a brain scan or an EEG that can give you an answer that's very concrete, it's a bit more variable.
So in the case you just read with the 6-year-old that was traumatized, abused, you're going to do brain scans and blood tests to see whether or not.
I think that's where the research potential is an unknown. We can't predict exactly where it will take us. I think there is potential for that kind of diagnostic test guiding treatment in the future. We've seen some of that with pharmacogenomics and the testing that they're beginning to do to look at how we can guide our prescribing practices based on people's genetic profile. That's just one example, but we're really early in that science. We're not there yet.
So we need to understand both the genes and the environment and how they're working together, but we need to be doing this in brain and in the brain cells. And unfortunately, until recently, we have not had access to brain cells from living patients. So now there is technology that allows us to do that. We can take brain cells, we can take blood cells or skin cells from patients that are being seen at the clinics, and we can actually develop neurons and other brain cell types and develop mini brains so that we can study the genetic background of that person, the environment that that person has suffered, and how that is actually changing brain function in that individual person, and develop personalized treatments for that particular person. I believe HB10 will allow us to have the resources, because this takes a lot of research and a huge effort. And until recently, we have not had that in mental health.
Is there an age bracket that we're looking at, or just anybody under the 18 years of age?
Well, actually, we think of disorders like schizophrenia and bipolar disorder as adult disorders because they usually manifest themselves in early 20s. But in fact, we know that these are actually childhood disorders that start early in childhood, triggered by a trauma. So it can really be any age.
Okay.
If you are genetically susceptible because you have the family history and you suffer from trauma, like many of the patients that Dr. Nolan sees, this can be across any age at which the brain is still developing.
State your name for the record, who you represent. You may begin.
Hello, my name is Dr. Denise Zimmerman, and I'm representing Spring ISD and myself, and I'm here to testify for House Bill 10. I am the Director of Mental Health in Spring ISD, and I'm a trauma consultant and instructor for the National Institute of Trauma Loss in Children. Having been in a school counselor position for over a decade, I've seen a dramatic rise in mental health concerns with our youth. Leads me to ask the question of why. What's going on? Today's research shows that suicide is the second leading cause of death in children ages 10 to 24, and 46.4% of all people will have a mental health crisis during their lifetime. In my district, with only 19 days of school in January, the counselors dealt with 491 mental health crises. That's enough to fill a 747 jetliner. These included 74 were suicidal ideation, 15 violent ideations, 72 CPS referrals or CPS concerns, 42 non-suicidal self-injurious behaviors, and 288 other mental health crisis and trauma-related incidences such as eating disorders, depression, anxiety, suicide, murder of a parent, incarceration, and etc. How do we deal with these issues? Through research to find out why, and through access to mental health providers.
Good afternoon, Chairman Thompson and members. My name is Wayne Sneed. I'm the Mental Health Supervisor for Austin ISD Police Department. I've served for nearly 37 years as a police officer. I've been a mental health supervisor within this department for 6 years. And during that time, we have 130 campuses that cover about a 235 square mile area of the city. This bill will help address two troubling trends that appear to be occurring amongst our students. Our school counselors are faced with daily crisis incidents that demands most of their time, which does not allow them to serve the students who have merely academic needs. The calls range from severe mental health crisis to completed suicide on our campus during school time. Suicidal ideations and other severe mental health issues among our youth appear to be increasing, and we're seeing this on the ground. For example, last year, 2017-2018 school year, suicidal ideations within our district were 878. Attempted suicides, 378. Non-suicidal self-injury, our cutters, 1,689. CPS referrals for mental health related issues, 875. Intensive counseling sessions, 4,815. Completed suicides, 6. This year, from August to mid-December 2018, our counselors and our staff have handled 1,300 suicidal ideations, 72 suicide attempts, 749 non-suicidal self-injury incidents, 875 CPS referrals related to mental health. Intensive counseling sessions are 1,000, and luckily this year, for the first time in 7 years, we've had 0 completed suicides. Age that this begins, that we begin to experience our mental health crisis is drastically falling. I had a 4-year-old child that I personally placed in a psychiatric hospital 4 times involuntarily in one school year. That particular child, the mother had a previous diagnosis of schizophrenia with psychotic features. The father had been diagnosed with bipolar disorder with psychotic features. This was starting to manifest in this child as early as age 4. So consistent with what you've heard previously, it is manifesting in our kids much earlier than what we think of schizophrenia at age 18 as an adult disease. We also had our first 9-year-old completed suicide.
Yeah, Representative Zetley.
Let me ask you this, could kind of give me an idea of how this would kind of be handled in order, when you, would you wait for a situation to occur that you thought needed to be addressed and you'd contact the student? Would there be initial interactions with the students? Or exactly how would, before you get involved, what would be going on?
I can answer for Austin ISD. Our calls right now are driven by crisis.
Okay.
So the crisis occurs and then we respond to try and mitigate the crisis. There's not a lot of science, as was indicated earlier, for us to go through to say, like a blood test. You can go in and do a blood test and get a diagnosis. So it's a constant challenge.
So y'all would hear, for instance, someone who's they had exhibit signs of cutting or something like that, then they would call the mental health counselor. Is that it?
From a counselor's perspective, I actually dealt with something this morning. I got a phone call. There was a youth who had suicidal ideations. The first person that is contacted is the campus counselor. The counselor will go and talk with the children. They do assessments to see what level of threat they consider the ideation at. At that point, we will make the determination if it's a phone call to the parent or not, and the parents are receptive based on that ideation level. And if the parent chooses to come and get the child to take them for an assessment, at that point, if we determine it's a high risk, then the parent, we give them resources to go places. But as it was testified earlier, there's not many places to go. It's very difficult to find places to take to children to be assessed. And then when they do find they need help, there's no place that has any openings to take them for months. And we're talking about a child who's threatening to either kill himself or do harm to someone else. So if the parent chooses not to come, at that point, unfortunately, because we have to take care of the safety of the child, we have to do neglect through CPS, and we call the police.
Question, you mentioned the mental health issues within CPS that were CPS reports. Can you give me an idea or a flavor of what those look like? Because I'm still trying to weigh in my own mind. To me, we're talking almost about 2 different issues. One is some of the schizophrenia, and they're truly acute issues. Then you have, I don't mean circumstantial mental health, which are still very serious, but when you do CPS and you say it's a mental health issue, what are the range of issues?
It could be a multitude of ranges. Majority of the time when we're doing CPS, it's because a parent either diminishes the value of what their child is making, the outcry, refusing to respond to the campus to be there to support their child, or we cannot contact a parent at all. And similar to what was testified to just previously, our scenarios are almost identical in different school districts, hers in Spring and mine in Austin. But the example she gave is pretty much that. The child's presenting as high risk. They have a specific plan. They have the means to carry out the plan.
So, I thought you said 700 or something in terms of number of CPS cases. All those were suicide or possible suicide?
Those are medical neglect cases, typically dealing with mental health to some degree.
I guess that's what I'm trying to, so somebody identifies, I think you've got a mental health issue, the parent disagrees, and we call CPS?
Correct, because the way they've been deemed is that they're at a serious risk of harm to self or others, and the parent is not being responsive to the request to come to the campus and deal with the situation.
Well, I guess I get it if it's a suicide. I'm trying to figure out with the number you gave, it's hard to imagine there was, I thought you said 743 or something, but maybe I forgot, but it was a pretty high number. It's hard to imagine in Austin ISD you had that many suicide outcries, so there's a lot of something else that is causing a difference between Austin ISD's mental health opinion and the parent's opinion that's causing intake to CPS, and I was just trying to figure out. I am concerned with overdiagnosis of mental health issues. I think we identify a kid that's in a bad spot, maybe we just took them out of their parents' home and we say they're suffering with depression. I'm like, yeah, they're suffering, you just took them out of their home.
Hi, my name is Judy Powell, and I'm with Parent Guidance Center, and we help children involved with CPS, well, parents of children involved with CPS. And we also do parental rights advocacy, legislative advocacy. We are currently against the bill as it's currently written. We have parental rights concerns as our main concern because we look at parental rights. Anytime you're looking at research, including mental health research, we want to ensure that consent is being done properly, and so we're looking at a research institute here, so we want to make sure that as any kind of research is conducted, that they have robust policies on fully informed consent versus passive consent and some other forms of consent. We want to make sure also that there are robust policies when a parent may be involved in consenting for a research project, but then wants to withdraw consent. We've actually had 3 medical cases where parents had consented initially to various research procedures, and when they withdrew, the doctors called CPS. So we are familiar with that retaliation happening when you do pull out, and I'm sure it's the same in the mental health arena. And that would ensure treatment choice for parents and their children. Another concern would be missing stakeholders. So this bill is just psychiatry, nursing psychiatry. So just like with HB10 over on the Senate side, it's a little bit different, but we saw missing stakeholders of like counseling organizations being involved, social work organizations, psychologist organizations. There's lots of good organizations that really need to be involved in this research that do some of these alternative therapies that you've already heard about. And so we want to make sure that, again, treatment choice is in there even when you're researching those treatment choices. A third concern that we have.
Can I interrupt you real quick?
Mm-hmm.
So on that point, are you talking about the actual composition of the institute portion of the bill?
Yes.
Okay.
Mm-hmm.
So
I just see the 12 teaching hospitals, and I think this one included an appointment by the governor from HJR5, one, trying to think of the difference between HB10. It had one.
Talked about a member of a nonprofit.
Nonprofit that deals with mental health. We didn't see any of these other organizations involved, and I'm sure they would be very happy to be involved in this sort of research.
A member.
And I'm not privy to the committee substitute, so maybe that was changed. I don't know.
So you want it expanded?
Yes.
Is what you're saying? Okay.
Mm-hmm.
Okay.
Yeah,
All
we
right.
wanted the addition of people that don't always use drug treatments as a first line of therapy. people
Well,
involved
okay.
in alternative
So that
therapies.
wouldn't, the representation by a member of the statewide behavioral health coordinating council, which may or may not be that description.
I don't think that would be full coverage of that, of those other organizations that,
Okay.
do counseling and some of the alternative therapies. We just want to make sure there's treatment choice out there, and that those other alternatives are being researched by our billion-dollar research institute. Number 3 is a concern of conflicts of interest policies for the institute. So in 2013, the Pew Charitable Trust put out a report on, it was called Conflicts of Interest Policies for Academic Medical Centers, which is the list of the 12. They fall under that. And their conclusion was, and I'm going to read from the report, conflict of interest policies at academic medical centers serve to strengthen and protect academic integrity while encouraging those principled relationships with industry that advance research and treatment. Ultimately, strong policies will maintain the quality of medical education and support patient trust in the medical profession. So we don't see anything about conflicts of interest related to this institute. And the representative talked about it being patterned after secret, and so I just want to remind you of some of those scandals that happened in 2012, and then you as a legislature had to come back and fix some of that and make some of those changes. And so we'd like to see, if you're going to do a research institute that's very similar, why not from the get-go make those policies apply to this research institute? So that would be our concern, just do that on the front end. And a fourth problem that we have is we don't see like a robust privacy policy. So any research institute you're going to have research subjects, and so especially in this bill, it's very prescriptive. And one of the things that concerns us is that the genetic component. They say they're going to include researching the most recent pharmacogenetic strategies, the genetic determinants of addiction, and the genetic causes of behavioral health issues. So any research, especially when it involves genetics, you need to have like even extra robust privacy protections, information protections for that information, because genetic information can really impact the future of people and the databases that it goes in and the tiebacks. When you start saying that you're mentally ill for genetic reasons, and then you're going to predict, oh, we think your kids are going to be medically ill, then, I mean, I hate to say the word eugenics, but it really makes me uncomfortable. And so when you put this prescriptive language in there, we really, from the get-go, need to have very robust privacy policies and where that information lives and who has access to it. So those are a few of our concerns with the bill, and I'd be happy to answer any questions.
Members, any questions of Ms. Powell? Representative Zettel.
So what you're saying is we need to absolutely make sure that the information is separated from any names of any students, that kind of thing?
Yes, and a lot of times I talk to like experts that they talk about, oh, information's de-identified. Oh, don't worry about it. Well, there's algorithms now that can or un-de-identify or whatever you want to call it. And we've looked into different registry lists and that sort of thing. And I've absolutely been told that even when you de-identify, if you don't have certain firewalls, etc., they can just put that information back together and then they sell it. And so, I mean, there's insurance, future employment implications, just like the one doctor said, like if it got out that, she had a mental illness, that could affect future employment, that sort of thing. So we're concerned
Yes,
about
sir,
that.
thank you. My name is Lee Spiller. I'm the Executive Director of the Citizens Commission on Human Rights, Texas, and I'm here to testify against the bill. But I gotta tell you this has been one heck of a discussion on this committee today. This is the kind of discussion that we've needed before these bills were filed. I know y'all tried to do it in the interim process, but that's just the thing. There's so many people at the table today, right? And that's kind of what's missing in this bill is who's at the table, right? This is a community problem. It's whatever it is, but we're focusing on one discipline, right? I was at a event with the Texas Supreme Court back in October, and Art Acevedo spoke, and he was talking about children's mental health. And he talked about that, and then all of a sudden he broke. And he said, but I wish y'all would do some programs out in our communities to handle the stressors before they become mental illness. And that's actually, he made a very good point. When you look at the Secret Service report on mass shootings, they had different people who had different characteristics. But they pointed out that virtually all of them had had major life stressors prior to their crime, and we're not getting to that in this bill. Dr. pointed out that, until the 80s, child depression was unheard of. The 80s was the age of Prozac. It was widely prescribed, and only around 2004 did they put a black box warning on that drug for suicide and suicidal thoughts in children. And that's been one of our concerns with, more telemedicine and more ways to push the medical model is, are we going to cause harm? Are we going to cause harm by this, right? And we're not trying to tell anybody what they should do with their child. We're trying to say, hey, let's step back, let's do informed consent, and truly inform people of risks. And then if they want to make that choice, great. But it's got to start with education. The things that Officer Sneed was talking about scared me to death. For about the past 2.5 years, most of the calls that we get are people who are in psychiatric hospitals and can't get out. And you had families talking about ending up at the hospital and then, basically being told that her child was going to be admitted to the psych hospital. And she pretty much had no choice. And there's been a lot of that. There is a hospital right now up in the Dallas-Fort Worth area that's under a criminal indictment, 20-count criminal indictment. And most of the allegations are related to holding people against their will. And I would just remind you, kind of like what the school people were laying out. Man, that's a lot of trouble, but these schools are also kind of a political environment, right? You're a troublemaker, you're having a problem, you're identified, and I worry that our schools are not the best place to deal with that because you've already got a history there, whereas your own parents, your own doctor would be the better place to do it. We had a case in 2004 of a girl who was mental health screened in her school in Pflugerville. And the team decided that she needed to be institutionalized, which wasn't supposed to be part of the program. And the parents wanted a second opinion. And I believe they got one. Whatever happened, about a month later, CPS showed up at the house, removed their daughter. She was sent to Austin State Hospital. She was forcibly drugged. She was restrained. And she ended up in Mother Jones magazine. If you Google medicating Amanda, you'll find the article. Right? No child should have to go through that. I don't know that we're not traumatizing children more by putting them in that situation.
State your name, please, and who you represent and your position on the bill.
Amy Hedke. I'm representing myself, and I am against this bill. The merging of education, state funding, and mental health is a very dangerous thing to start. I'd posit that the rise of mental health issues in schools is an inherent problem of the institutionalization of children and won't be cured by these bills. Yesterday, a gentleman testified that the suicide rate is higher during the school year. That's not a coincidence. There are multiple federal and state laws that are already expanding state longitudinal data systems to collect and share personally identifiable data on our children. Essentially, all data collected on students from preschool through the workforce will follow them the rest of their lives. The main proponent of a lot of these mental health legislation bills wants universal mental health screening, and the governor's own 44-page school safety plan identified mental screenings as part of his agenda. This is essentially a backdoor red flag program. The law enforcement testified this past summer that Texas already has the authority to involuntarily commit someone to a mental health facility for assessment and treatment for 48 hours. And that doesn't include weekends. And the representative was right. These are very, very complicated. There's no concrete answers in the field of mental health. They're not all caused by tumors, and there's no blood test for mental illness. On a personal level, as one of many Texans who are politically active and have children in public schools, I am very concerned about the expansion of mental health care into the school system. Psychiatry possesses a built-in capacity for abuse that is greater than in other areas of medicine. The diagnosis of mental diseases allows the state to hold persons against their will and insist upon therapy in the broader interests of society. Licensed psychiatrists have been involved in human rights abuses in states across the world, including here in the United States. In addition to controlling political dissidents, other populations are at risk of psychiatric abuse. By 2011, antipsychotic drugs grossed over $18 billion a year in the US, making antipsychotics the highest grossing class of drugs. Much of this growth is attributable to the prescribing of antipsychotics to non-psychotic people in specific groups. These populations include foster children, the elderly in nursing homes, and inmates in prisons and jails, where antipsychotic drugs are an inexpensive way to subdue and manage them. Enter the K-12 public school population, an automatic captive cash cow for the pharmaceutical and research industry. Did we catch the research potential of this bill? The children of Texas are not lab rats. The history of psychiatric abuse on minority populations is well documented, and it would be naive to assume that won't continue to happen. A previous witness said she hates to use the word eugenics because it's not a hypothetical thing. It is a stark reality, and no legal requirement to separate names from info is going to stop that. You guys don't need more psychiatrists in schools. You need to revamp your educational institutionalization of children and find a healthier way to implement public education. Your current system is killing your kids. The state has created the crisis that you're seeking to fix. Treating the symptoms with no understanding of the cause is negligence and harmful to children, which is exactly what many people are looking to do just so they can get access to federal grant money and students. In short, to address the underlying political agenda of these mental health bills, there is absolutely no evidence that the state of medical science in the mental health field allows us to identify future criminals or someone who is suicidal, nor do professionals in the field claim any such thing. Furthermore, if we establish a regime in which those diagnosed with mental illness may lawfully be denied their Second Amendment rights under red flag programs, there can be no doubt that prospective patients, their families, and even their physicians will be more reluctant than they are at present to be so diagnosed and identified. The fear of this stuff is real, not so much because of the social implications, but because of the legal implications. So y'all need to watch how you're proceeding on this stuff.
Not, the testimony on House Bill 10 and on HJR5 is now closed, and the chair recognizes Chairwoman Thompson to close on the bills.
This bill is designed to be research-driven, to try to come up with the answers to some of the whys that we don't know. And we're hopeful that through starting this research, that we're going to be able to go down the roads to unraveling some of the triggers that are causing these problems in the brains of children, the trauma, the suicide, and the other things that we've been talking about, and things that we don't even know yet. Just like when I was a teacher that had never heard ADD and ADHD because they were not a part of the medical lexicon at that particular time. But I can tell you this, what do we have to lose? We are at zero now. Must we continue to set at zero because somebody is afraid of research and trying to find help? I dare think of what would have happened when the person they find the research and some of the answers to polio and syphilis and gonorrhea. If they had sat down and done nothing, just think where we would be today. We're not trying to take anybody's children, and we're not trying to force medication on anybody.
I wanted to address something else. Ma'am, you had asked earlier what are people afraid of in research? And what do we have to lose?
Pardon me, please.
You had the gall to reference syphilis research, like the horrific research on 600 black men in Tuskegee who were lied to and intentionally not treated.
That's not the bill before us, ma'am.
No.
This is how.
But when you make a statement like that, it needs to be called out. If you can't recognize the pitfalls in research and how dangerous it can be, somebody needs to point it out publicly. Research has a long history of major, major problems. People have died from this stuff. Don't do that.